I have a patient with a non-traumatic swollen ankle. Is there an effusion? And if there is, what's the best way to tap it? We're going to answer both of these questions with my favorite tool, ultrasound. First, we will look at the ankle with ultrasound to see if there is an effusion. Optimal patient position for this is with the patient supine or seated, with the heel against the edge of the bed or stretcher, so that it can be flexed or extended as needed. Since we are examining a fairly superficial structure, we will use the linear high-frequency transducer. If you have a high-frequency hockey stick transducer, you may want to use this for pediatric or very small joint. You'll want to use a preset for superficial or musculoskeletal structures in order to optimize your view of the joint space. We have selected the ankle preset on our machine. Eli is applying a thick gel cushion to the anterior and medial aspect of the ankle. We're going to look at the joint in the sagittal plane. So the transducer is placed with the indicator towards the patient's knee. On the ultrasound screen, the indicator marker corresponds with the transducer indicator. So the patient's knee is towards the left side of the screen and the foot is towards the right. The joint space can be examined in 3 places. The first is between the medial malleolus and the anterior tibial tendon. The second is just lateral to the anterior tibial tendon, and the third is far lateral at the fibular-talar joint. The preferred space for arthrocentesis is between the medial malleolus and the anterior tibial tendon. Ultrasound images of this view demonstrate the tibia towards the left side of the screen and the talar dome towards the right, with the normal joint space in between. When an effusion is present, an anechoic or hypoechoic area will be seen pushing out of the joint space. Now that we've established the presence of an effusion, we need to perform an arthrocentesis. That effusion looked pretty small to me, so I'm going to use ultrasound to ensure that I get the fluid I need for analysis. Arthrocentesis is a sterile procedure, so we have prepped and draped the ankle. Our syringe and needle are also on the sterile field. In addition, the ultrasound transducer has been covered in a sterile transducer cover, and we are using sterile gel. Please see the Access EM procedural video on ultrasound-guided internal jugular vein cannulation for a demonstration of how to apply a sterile probe cover to the transducer. Machine placement is very important for ultrasound-guided procedures. You want to place the machine so you don't have to turn your head to go back and forth between the procedure and the ultrasound screen. I've placed our machine just to the patient's right, so Eli only has to look up to see the screen. The skin has been anesthetized and we are ready to proceed. The transducer is held by the left hand in the sagittal plane and the ankle flexed and extended slightly to optimize access to the joint. The center of the long face of the transducer is placed directly over the middle of the joint space. A 19 or 20 gauge needle attached to a syringe is inserted at the center of the long face of the transducer, angled just slightly towards the transducer. Placing the joint space in the center of the screen and then placing the needle at the center of the transducer is key to successful needle placement in the joint space. Insert the needle right next to the middle of the transducer. The hyperechoic needle tip is visualized in the center of the screen as it enters the joint space. Once the needle tip is visualized, gently draw back and voila! Joint aspiration is complete. Identification of joint effusions and joint aspiration is easy with ultrasound. The keys to success are preparation, proper positioning of the joint, and accurate alignment of the needle with the transducer. Next time you have a patient with a swollen ankle, take a look with ultrasound.